Okay. So Matt, I assume that we are live with the breast committee meeting, right?
Yes.
I don't really see how many participants have logged in, but I assume that we have a fair number of people who actually took time to join us. So I would like to welcome each of you who took time to join the spring SWOG breast committee meeting. And I hope that this will be the last one that we have to do online. I really miss the personal interactions, particularly the discussions that we have on the corridor and during our breast committee dinner. So somewhat breaking with the protocol, I would like to acknowledge and thank the people who actually make this meeting really successful and meaningful for us, particularly my co-chair, Priyanka Sharma, also the translational medicine chairs, Alistair Thompson, Andy Godwin, and the SWOG Operations Center, particularly Kara Lobak and Willie, who really put a lot of effort to put this program together. And of course, the irreplaceable Bill Barlow, who keeps our data and keeps us straight with regards of statistics. I think we have a very exciting set of agenda and invited speakers. So I would like to move to the next slide, which is a few housekeeping items. So can somebody move the slides for me? Yeah. So the most important thing is the Q&A. If you type in a question into the Q&A, this comes to the committee, to us. On the other hand, if you actually put in a question into the chat box, then you can direct it to everybody and also to somebody who actually you choose as a private sort of target for your message. I also would like to point out to you that we would like to hear your voice, but to hear your voice, you will need to raise your hand. And Matt, who is our technical support person, will unmute you, and you can actually ask a question to the entire committee that we can hear. Next slide, please. So I'm sure that COVID has impacted our lives in many ways, professionally and personally as well. So we put the mini symposium around the COVID theme, and we will have three exciting but short presentations. The first one is from Clara Park, our very own Clara Park, who will discuss the impact of the COVID pandemic in neoadjuvant endocrine therapy. So I would like to invite Priyanka Sharma to introduce Clara.
Thank you, Lavish, and we welcome all of you to our meeting. I see we have 110 participants joined in, so thank you so much. Our first speaker for the mini symposium is Dr. Clara Park, who's Assistant Professor of Surgery at the Ohio State University James Comprehensive Cancer Center. And she's breaking her OR time to give us this presentation. She's a breast surgeon, health service researcher, with a focus on implementation sciences, and will present to us some very exciting data that she generated using SWOG resources. So Clara, the stage is yours.
Thank you so much for giving me the opportunity to virtually meet with you all today. And I'm happy. I'm sure the fellow is very happy that I have left him in the OR to join this conference today. So let's see. Okay, there we go. I apologize. I am masked currently, and so I did include a photo of myself in case you're wondering what I look like under here. And today we're going to discuss the neoadjuvant endocrine therapy use in early stage breast cancer during the COVID-19 pandemic, which is a survey actually that many of you have participated in. And so thank you so much. I am a breast surgical oncologist and a health services researcher with a focus on implementation science. And the entire premise of implementation science is to bridge the gap between evidence-based practice and real-life practice. And like many of you, my life has taken some turns during the COVID-19 pandemic. And I began to think about the pandemic as yet another barrier when it comes to implementing evidence-based practice. Many of us in the audience have experienced COVID-19 personally and have patients with the COVID-19. And the pandemic really affected all aspects of breast cancer care, including screening, clinical trial enrollment, survivorship, as well as therapy. And so when the pandemic was first announced, now over a year ago, In the United States, in an unprecedented manner, the CMS and the American College of Surgeons recommended limiting all non-essential surgeries. Weighing the relative low risk of disease progression and early stage breast cancer, many medical societies specifically recommended short-term delay of surgery in early stage estrogen receptor positive breast cancer. As a consequence, the use of endocrine therapy during deferment of surgery was recommended in many instances. The increased use of neoadjuvant endocrine therapy was demonstrated in recently presented studies. This is the American Society of Breast Surgeons COVID-19 registry data, and they presented this at the recent San Antonio Breast Cancer Conference. They had, at the time, 1,781 patients from 154 surgeons inputting the data, and the pandemic significantly led to significant modifications in breast cancer treatment, including, as you can see here, high use of neoadjuvant endocrine therapy, as well as genomic assay testing on core biopsies and resultant delays in surgery. Similar patterns were recognized in international studies as well. The use of endocrine therapy has been demonstrated in this Netherlands study, which was also presented at the most recent San Antonio conference. And they found that in stage 1 breast cancer patients, neoadjuvant endocrine therapy increased to 11.7% compared to 2.9% in historical times, as well as in stage 2 patients, the neoadjuvant endocrine therapy use increased to 20% compared to 6.7% in 2018. Not surprisingly, the use of chemotherapy decreased to 21%. So when you put yourself back from a year from today, we didn't have those data, obviously, that I had presented. And so virtually every single tumor board, I remember we were discussing how do we safely delay surgery in the context of the pandemic. So I reached out to many of my mentors here in the audience, including Dr. Lester Thompson and Miriam Lusberg, and I discussed with them, what are we going to do when we're recommending neoadjuvant endocrine therapy? Because historically, neoadjuvant endocrine therapy use in early stage breast cancer in the United States has only been around 3%. And so given the historical low utilization, we wanted to understand how physicians were using neoadjuvant endocrine therapy as an ultimate treatment method during the pandemic. A lot of the questions that you helped answer in the survey were based on real life management quandaries that we encountered. And the objective of the stakeholder assessment was to determine physician attitude and treatment preferences with regards to neoadjuvant endocrine therapy. How long are we delaying surgery without it? How long do we plan to use it? And what do we do about the axilla after neoadjuvant endocrine therapy? A provider survey was validated and developed, and we administered the survey from May 8th through June 12th to many of the U.S. medical radiation oncologists and surgical oncologists. We engaged with the cooperative groups, specifically the SWOG and Alliance, and also found some additional providers through chain referrals. We've identified a total of 114 respondents, and 30 of them came from Alliance, 35 from SWOG, and 45 from chain referrals. Majority of the survey participants, 64% to be exact, had their practice dedicated to breast oncology. Survey participants came from the following 29 states. So we had, despite the short time period that the survey was active, a very good representation of United States practitioners. And here's some of our data. Prior to the pandemic, 46% of the respondents stated that they rarely used endocrine therapy for early stage breast cancer, and only 12% stated they used endocrine therapy often. Because of the pandemic, nearly half, or 46% of the providers, were willing to delay surgery up to 2 months without endocrine therapy, and a smaller portion, or 21%, up to 3 months without endocrine therapy. Majority of the physicians changed their practice due to the pandemic, and 66% stated that it was based on a multidisciplinary tumor board discussion rather than an explicit institutional mandate to delay surgery. At the time, now put yourself a year from today, this was administered back in May of 2020. At the time, only 9% stated they did not need to change their practice at all. The planned duration of endocrine therapy varied significantly by specialty. As you can see here, 62 to 75% of surgeons and radiation oncologists plan to use endocrine therapy for as little time as possible, while medical oncologists were divided. 34% of medical oncologists plan to use endocrine therapy for as short of time as possible, while 39% actually plan to vary the duration based on the patient's risk factors, such as tumor grade, percent of hormone positivity. There were no significant differences in planned duration of endocrine therapy by physician characteristics, such as years in practice, percent effort of practice in breast, region of practice in the United States, or average COVID-19 cases in May 2020 when the survey was administered, practice setting, nor geographic settings. The most preferred regimen for endocrine therapy was tamoxifen for premenopausal women and aromatase inhibitors for postmenopausal women. However, medical oncologists were more likely than surgeons and radiation oncologists to recommend ovarian suppression with aromatase inhibitor for premenopausal women. In fact, 37% of medical oncologists recommend aromatase inhibitors with ovarian suppression rather than tamoxifen alone. We asked physicians if they're using neoadjuvant endocrine therapy, how are they using genomic assay in that setting? Of note, at the time of the survey distribution, the SWOG 1007 RX Ponder data was not yet to be presented at San Antonio. And most of the providers stated they would perform a genomic assay on the biopsy specimen on all or select patients prior to endocrine therapy initiation. And medical oncologists were significantly more likely to send genomic assays than surgeons. The reason we asked this question about the genomic assay on core biopsy was because of the concern of discordant findings on genomic assay from after endocrine therapy treatment initiation. And these studies actually demonstrate, as you can see here, that the average increase in the 21 gene recurrence score is only about a factor of 2 or 3, and so it doesn't significantly change their risk category, even if the patients receive significant duration of neoadjuvant endocrine therapy. Next, we asked the physicians how they're going to stage the axilla prior to starting endocrine therapy. None of the providers stated that they would recommend sentinel lymph node biopsy prior to the start of neoadjuvant endocrine therapy. And 26% of the physicians stated that they would stage the axilla with physical exam only, while 71% stated that they would do physical exam in addition to axillary ultrasound to stage the axilla. And only 4% of the physicians stated that on top of those two modalities, they would add either a CT scan or MRI to stage the axilla. That's the propensity for completion axillary lymph node dissection in a patient that otherwise met Z11 criteria. We asked the participants how they would manage the axilla in the following clinical scenario of a 48-year-old female with grade 3 invasive ductal carcinoma that was hormone receptor positive and clinically node negative. At the time of the lumpectomy and sentinel lymph node biopsy, she was found to have 1 micrometastasis in the sentinel lymph node. And we asked the participants, would you omit axillary lymph node dissection depending on the duration of endocrine therapy? Not surprisingly, for a shorter number of endocrine therapy, between 1 to 3 months, majority of the participants said that definitely yes, we would omit axillary lymph node dissection. With longer duration of endocrine therapy, however, the propensity for omitting ALND did decrease, hinting that physicians did not think ACOSOG Z11 necessarily applied to this clinical scenario of endocrine therapy. Omitting ALND was not associated with physicians' years in practice setting or type, or their participation in multidisciplinary tumor board, or the number of COVID cases in that particular practicing state. After 6 months of endocrine therapy, providers with the greater percentage of their practice dedicated to breast cancer actually had an increased likelihood of completing ALND with a p-value of 0.039, but this trend was not significant after 1 year of endocrine therapy. So some of the major findings from this study, I believe, are with regards to key patterns in neoadjuvant endocrine therapy and physician attitude towards endocrine therapy during the pandemic is that indeed physicians stated that endocrine therapy prior to the pandemic was low, and most of them planned to use endocrine therapy as short of a duration as possible until surgery could safely proceed. There were no differences in planned duration of endocrine therapy by physician characteristics such as years in practice, percent of their practice dedicated to breast versus other oncologic disciplines, region of the United States or where they practice as far as their geographic setting or their practice settings such as academic versus community-based practice. And omission of axillary lymph node dissection in low volume axillary disease did vary by the duration of endocrine therapy, where with longer duration of endocrine therapy, the propensity to complete ALND did increase. So what are some major takeaways from the current pandemic with regards to this topic? I think the COVID-19 pandemic is definitely unprecedented in modern times. However, we can definitely draw some parallels compared to the impact of natural disasters such as hurricanes on cancer care delivery. This is a pre and a post Hurricane Harvey photo that I took when I was at MD Anderson in Houston, Texas during the time. And past studies on natural disasters have demonstrated delays in cancer treatments, in particular related to delays in patients seeking care after the onset of noticeable symptoms. And many of you are experiencing that with decrease in screening mammograms. However, the change in management to a less popular regimen, such as neoadjuvant endocrine therapy, has not been described previously. And furthermore, unlike natural disasters such as hurricanes, where there's a single major catastrophic event in a short time period, the current pandemic, as we all know, is lingering on with recurrent surges globally. As endocrine therapy use dramatically increased during pandemic times, I think many questions remain regarding the management of estrogen receptor positive breast cancer, such as how do we manage the axilla? How do we best use ovarian suppression in premenopausal women? What's best practices as far as genomic testing goes in core biopsy specimens? And I really do think now the timing is ripe to take a greater look at neoadjuvant endocrine therapy in this patient population. And I know that there are numerous endocrine therapy clinical trial concepts currently underway at the cooperative groups, and I really look forward to actively participating in these clinical trials. Of course, this study could not have occurred without many of my great mentors. A lot of you are online here today, and I thank you immensely. And I thank you especially the SWOG Breast Committee for participating in the survey. Thank you.
Thank you, Clara. I would like to ask you to please write down your questions or send it as a QA or a chat, and we will have about 10 minutes at the end of the presentations to discuss each of these presentations. I would like to introduce our next speaker, Dr. Balázs Halmos. Dr. Halmos is a professor of medicine at the Montefiore Medical Center, Albert Einstein College of Medicine in New York City. He's also the director of the Thoracic Oncology Program and the Cancer Genomics Program. He really has contributed and was instrumental in many of the therapeutic advances that happened in lung cancer in the past 15 years, including developing the EGFR inhibitors, the ALK inhibitors, and immuno-oncology drugs. However, we invited him for this event because of his recent work on the impact of COVID on cancer patients. Dr. Halmos was part of a committee or a group that formulated guidelines for COVID vaccination and also led and participated in many of the seminal studies that established seroconversion rates of cancer patients during treatment and also the case fatality rates for patients with COVID and cancer. Also, a bit of trivia, Balázs and I, we both graduated from the same medical school in Hungary, and I'm embarrassed to admit that this was in the previous century. So Balázs, welcome, and we look forward to hear your talk.
Thank you so much, Lajos. You're one of the very few people in the United States who's able to pronounce my name correctly, so I appreciate that. Can you guys hear me okay? Yeah, so it's a great pleasure to be here today, and I think the main reason I've been invited because we've been in the unfortunate situation anyway at Montefiore to have had a lot of patients with COVID in the beginning of the pandemic, and we definitely have tried to take an effort to contribute to general knowledge and had a recent paper, that I'll be able to present to you. But before going to more recent information, let me just step back a little bit, and I'm just hopeful that I'll be able to advance the slides. I know that there's a bit of a time delay. It's happened yet. Okay, so stepping back about a year, of course, we were all taken by complete surprise by the COVID pandemic, but no city was hit as heavily and as with such a surprise as New York City last March, where the first case was diagnosed March 1st, actually in New York City, and our first case at Montefiore came in on March 11th. And within a span of 20 days, we had 2,000 cases within our health system, with 95% of all of our beds filled with COVID-19 patients. And between March and June, we hospitalized 12,000 patients altogether with COVID-19. Unfortunately, lost many. And many of our employees, of course, suffered significant consequences, including a number of our employees unfortunately dying. The summer was a quiet time, but we're back at the second peak, which slowly seems to be settling down, fortunately. And hopefully this is the result of vaccinations besides good behavior, and we'll see it now continuing. But as the pandemic started, it became very quickly clear that the pandemic hits patient populations very differently. The first couple of weeks showed that most of the cases of patients coming to hospitals in New York City and having very adverse consequences, including death from COVID-19, had a lot of comorbidities, and also were very elderly patients many times. And of course, cancer, showed up as one of these comorbidities in the first lists. And what we sensed even more so at Montefiore, serving an 80%, 90% minority population, is the racial differences in terms of how our populations have been adversely impacted between Blacks and Hispanics, averaging 2 to 3-fold higher, morbidities and mortalities in New York City than their Caucasian counterparts. So we felt kind of a sense of responsibility as oncologists to focus both our patients with a cancer diagnosis, but also making sure that we're able to provide the right care for our minority patient population in the middle of the pandemic. And with a couple of colleagues, put together the first large cohort of COVID cases amongst patients with cancer diagnosis, and found in a paper in last April in Cancer Discovery, of course, as we know, very high mortality in patients with malignancies, up to 28%. To put it in context, of course, this was the first wave, the sickest patients who had to come to the emergency room. Later on, of course, these figures improved. But it gave us a sense of, the massive nature of this pandemic impacting our patient population. But besides describing the mortality figures, we wanted to look a little bit more closely as to which are the patients who are impacted by COVID-19 more. And what you can see here is two different things. One is that we had the luck of having a good internal control in a way from Montefiore of age-matched patients, having a mortality figure of 14%, half of that of our patient population with cancer, but also New York City-wide mortality figures of 6%. So certainly it did seem the cancer patients, take a lot more of a toll with COVID-19, and very specifically elderly age and multiple comorbidities, as well as a poor performance status, stood out as the drivers of poor outcomes amongst our patients. And what we also observed some impact of different types of malignancies, and maybe not so surprisingly, heme malignancies, many times impacting elderly patients and leading to immune suppression, as well as lung cancer, again, impacting a patient population with severe lung disease and comorbidities, stood out as the patient cohorts with the highest mortality. As we face this, we realize that our patients with cancer face a real Scylla and Charybdis type situation. They're between the rock and the hard place. They have to be very afraid of COVID-19 outcomes, but they have to find ways of receiving appropriate attention for cancer treatment as well. So we developed this little protocol in a way, which we call the cancer patients PPE, providing strategies to prevent exposure to COVID-19 for patients who could, avoid that, providing telemedicine, holding treatments for the frail elderly where the indication wasn't strong, protecting the patients who needed exposure to the healthcare system through a number of different measures, separating COVID negative and COVID positive units, et cetera. But even more importantly, enabling cancer patients to receive the attention and the cancer therapies that they need. And we've continued with this PPE strategy, hopefully quite successfully ever since. Kind of digging in, realizing that this pandemic is going to continue. Sisyphus needs to continue to work, although mostly from home, but still the work needs to ultimately get done. So as we enter this phase, we realize that there's some large national efforts that we should really be contributing to, as opposed to just making local observations. And one of these fantastic efforts came actually from a medical resident who tweeted about putting together a registry, ultimately leading to a registry, CCC19. You guys are familiar with it, led by Jeremy Warner at Vanderbilt, now contributing a much larger scope of data from thousands of patients with makeup that you can see here, 82% solid tumors, 80% solid tumors, 20% heme malignancies, basically showing now in this larger cohort, a smaller figure in terms of mortality, 13%. Again, the explanation for that is very simple. This is now a little bit later in the pandemic. Patients with lesser symptoms could be diagnosed. This represents a patient population where only 50% got hospitalized, but still very significant mortality. And what I think I find the most stunning from this cohort is the range of morbidity that COVID-19 can lead to, from a 0% mortality for an ECOG PS0 young patient without comorbidities, to almost 100% for certain select patient population with poor performance status and respiratory compromise. So a very, very large spectrum of outcomes. And again, just like we noticed in the first place, now on a much larger level, we were able to prove that older age, poor performance status, comorbidities, as well as progressing malignancy are contributing factors to this higher mortality, morbidity. And as I mentioned, heme malignancies stood out, and in addition, active cytotoxic chemotherapy as risk factors as well. And from this on, I don't think we've learned that much more in terms of the impact of COVID-19 as to morbidity, mortality. We've learned a little bit, from inflammatory markers and very specific immune suppressive treatments. But the bottom line is elderly comorbidities, poor performance status are the key risk factors. Since that time, we've seen hundreds of papers trying to kind of replicate this information, replicating it. And at one point, it didn't seem like we're learning much from it. But what we've noticed at Montefiore from the CCC19 experience is that one very positive predictor of outcome has been a major improvement in outcomes of our cancer patients between last March and now in September, November, 64% improvement in mortality, suggestive that we're making a difference, not just with the earlier diagnosis, but maybe our treatment interventions are improving as well. There's more and more patients surviving COVID-19, which led us to decide to take a completely different approach researching this by looking at now the survivors of COVID-19. What you can see here is a course that just came out a couple of days ago in Nature Cancer, looking at our entire cohort of patients with a cancer diagnosis at Montefiore and narrowing this cohort down to patients who've had a COVID-19 PCR test for whatever reason, and then had an IgG test, an antibody test in relationship with that, understanding who actually develops immunity to COVID-19 after the viral infection. And here you can see on the right side our cohort, being shown in terms of the distribution, about 40% African American, 40% Hispanic, reasonable distribution of different cancer types, 77% solid tumors, 23% heme malignancies. And what you can see is that 92% of the patients became seroconverted, seropositive after COVID-19, And again, we had an internal cohort of patients here at Montefiore, and that's exactly the average rate of seroconversion for a patient without a cancer diagnosis. It would be 93% otherwise. But there was a cohort of patients who didn't seroconvert. And as we looked at those patients very specifically, and they represented a large cohort of patients with different types of treatments, chemotherapy, immunotherapy, bone marrow transplants. But we realized that there were very specific underlying disease factors that contributed to the lack of seroconversion, the lack of becoming seropositive after COVID-19. And the main risk factor seemed to be having a hematological malignancy, which on a certain level is the most logical observation. These patients can be severely immunosuppressed based on the underlying disease or based on the treatment that patients had received. And when we looked at the very specific treatments, what we could see is that it wasn't just only 80% of heme malignancy patients seroconverted, but if a patient had a stem cell transplant, that went down to 60%, and same thing for anti-CD20 therapies. Again, super logical observations on a certain level. Now, from a breast cancer standpoint, breast oncologist standpoint, what was very, very reassuring is that patients on endocrine therapy had a nearly 100% seroconversion rate. Again, super logical. These are patients with an intact immune system. And what we also observed is 100% seroconversion amongst patients receiving immunotherapies. An interesting side observation was that actually almost half of the patients presented with minimal or no symptoms. They were just found to be seroconverted. So even amongst patients with a cancer diagnosis, asymptomatic infections do occur, and they do occur a lot more commonly in solid malignant patients as opposed to patients with heme malignancies. And the same cohort also gave us a chance to look at shedding rates, and what we saw was a doubling of shedding rates in terms of shedding time, 60 days versus 33 days between heme malignancies versus solid tumors. We always complain about reviewers, but our reviewers are very nice. They actually gave a lot of good feedback to our paper and asked this very specific question: how about steroids? It didn't occur to us, to be honest. We looked back and we were able to find that actually, if you were on baseline steroids starting, with the COVID infection, or you received steroids for the treatment of COVID-19, seroconversion was also lower. Of course, patient numbers here are small. So from this cohort, what we learned is that, first of all, even amongst patients with cancer, COVID-19 can be asymptomatic or minimally symptomatic. The severity is worse in heme malignancies, and the shedding is more likely to be protracted. Seroconversion rates are fortunately very high amongst the large cohort, but yes, indeed, there's very specific subsets, very logically, where seroconversion rates are low, and likely this will inform vaccinations as they are coming out. Of course, rapid vaccination of patients with cancer is very critical, and there will need to be some special focus on patients with heme malignancies as to they might not respond to vaccinations as we anticipate, and they might need some very passive immunization strategies such as antibody treatments to be able to protect them, for example, transplant patients. So this was our recent paper, and this is our research group, and it's been just such a pleasure to work with our fellow, Asha Thakkar, leading the effort, 3 medical residents, and many of them actually did contract COVID-19, but also our breast cancer leader, Joe Sperano, our champion here at Montefiore, who's been a critical part of our efforts through the years and including last year as well. So very briefly, and I think I'm running low on time, secondary damage from the pandemic, and this is what we all need to deal with. Patients with cancer have been hiding out for a year, not coming to attention. Lung cancer screening rates have been pretty much 0 for 6 months. And the same thing goes for other screenings, down 90-95% early in the pandemic. Clinical trial accruals have been hit in major ways. And we all need to pay attention and invest more efforts to recover those, because cancer still remains, the second leading, cause of death in the United States, despite COVID-19, of course, having made a huge impact for last year. So all of us in the oncology field have to retain our focus, and I have to get our patients vaccinated, but the whole communities as well. And I feel so lucky now to be able to present positive data about the United States as opposed to last year, where we've been ashamed of how we've done. Finally, the U.S. has taken a real lead in the world, and our vaccination rates are super high. not as high as the little country of Bhutan, which decided in one weekend just to vaccinate everyone. That's going to be hard to catch up with, but we're doing quite well. And we're seeing the impact of that. I think cancer death rates are coming down, and COVID-19 death rates are coming down very nicely. We have to keep pushing this. And lastly, let me just say that it's not just the United States, but Lajos, my birth country, Hungary, is doing quite well here as well. We're the #1 country in the EU when it comes to vaccination rates, so I feel good about that as well. I know that you guys wanted to hear about vaccinations for cancer patients as well. Data is coming out this week and should be coming out in the coming weeks in large numbers. The data that we've seen so far is very limited and not very helpful, I think, but there's definitely been a couple of observations that certain heme malignancy cohorts are not converting all that well, with the current vaccinations. And I think we need to see better papers to really be able to feel confident with that information. They should be coming very soon. In the meantime, the recommendation is to vaccinate everyone with the malignant diagnosis, of course. Post-transplant, the current recommendation is to hold off on vaccinations for 3 months or so, as their immune system will not respond. And I think the same thing goes for some of the T-cell therapies. But we're trying our absolute best to vaccinate everyone here at Montefiore, and I'm sure you guys do the same. So hopefully the next SWOG meeting will be in person again, and hopefully one day I'll make it to another breast meeting as a thoracic oncologist. So thank you for the invite, and I'll stop there.
It's great. Thank you, Balazs. So I would like to invite Andrew Godwin to introduce our next speaker.
Yeah, so another part of the impact of COVID-19 pandemic is the process regarding biospecimen collection within clinical trials. I've led biobanking activities and efforts over the last 25 years and felt it would be informative to learn changes in banking practice. So it's my pleasure to introduce Nilsa Ramirez to talk about changes in the SWOG biobanking procedure since the pandemic started. Dr. Ramirez is a professor of clinical pathology at the Ohio State University College of Medicine and is the medical director of the Biopathology Center at the Abigail Wexner Research Institute at Nationwide Children's Hospital. So I'd like to invite Dr. Ramirez to update our SWOG members regarding ongoing banking activities. So Nilsa, can you, are you on?
Yep, I'm on.
Okay.
So thanks for the invitation. Just give you some background about our biospecimen bank. I'm the contact PI of the U24 grant, which is an NCI grant that supports our operations. And Dr. Jimmy Ray is the other PI of the bank, and together we coordinate services. And on a practical aspect of things, I oversee the day-to-day operations of the bank. Can I have the next slide? Thank you. So our bank is located at the Biopathology Center, which is part of the Research Institute at Nationwide Children's Hospital in Columbus, Ohio. And we did encounter some very complicated pandemic-related issues, especially during the month of March of last year. One of the important things for us was that our services associated with the acquisition, processing, banking, and distribution of specimens were considered essential by Research Institute leadership. That was very important because in many other research institutes, research laboratories were at least temporarily shut down. We were never out of put in that predicament. We were actually treated the same way as the clinical labs. And we developed a stronger partnership than the one we currently have with the clinical laboratories of the institution and also the laboratories in the city of Columbus, including those at Ohio State. So we had a network, and we kind of participated in sort of some of the items that we were experiencing, some of the issues that we were experiencing, and sharing that information between each other so we could do the best we can to keep not only the specimens safe, but also, of course, our personnel. Initially, we changed our hours So the laboratory personnel that was receiving processing, doing the nucleic acid extraction, distributing specimens, they work on split shifts from 6 to 11:30 p.m. from Monday to Friday and have a day on Saturdays to accommodate the demand and social distancing guidelines. So those of you that, some of you may know this, but we also serve other NCTN banks like Children's Oncology Group and the former GOG, which is now part of Energy Oncology. So in a daily, on regular days, we receive about 1,000 specimens a day from the U.S. and some other out of the U.S. Clinical trials that also bank their specimens here. So we had a sudden change in the number of specimens that we were receiving on a regular basis. The majority of non-laboratory personnel work from home, and we still have some people working from home, especially the IT group. But a lot of those people initially, we just sent everybody home except those that were working in the laboratories or had anything to do with the laboratories. And like any other institution, we did have some infected employees in different areas, and we have to follow institutional guidelines to deal with personnel-related issues like closing some of our laboratories or moving people to other laboratories that could serve as a backup. Next slide. So we started dealing with the central offices at SWOG almost immediately. We provided the SWOG Statistical and Data Management Center with weekly updates in an effort to let everybody know the status of our operation. And we have a great partnership with the statisticians. So that information was posted on a weekly basis on the SWOG website in the news and events section. And this practice ended in July of 2020 when we felt that our operation was just starting to turn and getting in a more pre-pandemic way of running our operation. We experienced some inquiries. One that comes to mind, there was an inquiry in early stages of the pandemic in March of 2020 about our daily operations by personnel affiliated with two of the melanoma studies. They were the first ones that called. They were interested in issuing a memo to their clinical sites to keep them updated regarding what was going on. So we did have a lot of inquiries from the leaders of some of the disease committees about what was going on, but because we were able to establish this relationship with the statisticians and have our stuff out in the SWOG website, things kind of calmed down and we sort of stopped receiving inquiries about what was going on. We participated in several conference calls that the NCI sponsored, especially CTEP, to discuss issues related to the NCTN groups and the ongoing pandemic. And those were very incredibly helpful for us, not only for the people dealing with the clinical trial process, but also us at the banks, and also keeping all the other banks, sort of keeping all of the NCTN banks in a network that we could communicate with each other. Regarding distribution projects, we only had 6 distribution projects that were put on hold at the beginning of the pandemic at the request of the investigators. Most of the requests were to stop processing the specimens or hold the specimen shipments. A lot of it had to do with the fact that the laboratories that were receiving the specimens were closed. So we were working with them just to see if they knew that something was going to happen or that they were going to be opening in 2 weeks, 3 weeks. Then we will establish some type of communication and just to be sure that the specimens will arrive at that lab when there's somebody there to receive them. 4 of those projects were eventually distributed between May and June of 2020. So this delay was very short-lived. And then 2 of the projects are still on hold, but those are reasons other than pandemic-related issues. Sometimes it has to do with investigators moving to other institutions or funding or things like that. So in reality, I don't think that this was a very significant delay. the consensus is here in the, especially the people that support the SWOG operation, is that they feel that we're back to normal operations or pre-pandemic state by about September of 2020. So we really didn't have the prolonged effect that the clinical sites have. We have inquiries from sites about submitting specimens from COVID-19 positive patients. Occasionally, people will call, I have this patient. Usually they will call and say they have a patient, the patient is being tested. What is it that they have to do if the patient is positive? So we have some discussions with them. We told them what our guidelines were. And as of today, we only have one case in the SWOG bank that is from a COVID positive patient that was submitted to us, and it was an ambient blood sample. Can I get the next slide? So one thing that was very interesting for the SWOG bank compared to all the other banking efforts that we support was that for a period of time from March to September, almost all the other efforts that we support, their numbers went down and then they went up around September. In SWOG, the numbers went up during the pandemic. And it had to do with a trial that was open around that time, S1714, and the specimens started coming our way, and they had a lot of time points. So that is why we ended up with 3,381 more specimens in 2020 than in 2019, which is an increase of about 27%, representing 291 more patients than the previous year. And then in the distribution of specimens, we distributed slightly more specimens than the year before in 2020, but those specimens that were distributed representing a larger number of patients. Like, for example, if you look at the distributed specimens, the total patients represented, the specimens from the number of patients that were distributed in 2019 was 166 versus 265 specimens from 265 patients being distributed in the projects. And the projects change every year. It all depends what was approved and if people are ready to receive them. There's so many variables, so it's very difficult to predict on a year-by-year basis, but I was surprised. I expected the numbers from both receiving and distributing to go down, and they didn't. Next. So we have a group, a formal group that goes by the Group Banking Committee of the NCTN. And this is an NCI-sponsored group that where all the different banks of the NCTN groups, we belong to this committee that oversees the function of the banks and trying to see if we can harmonize our standard operating procedures. And in the context of that group, the issue of what are we going to do, can we develop some guidelines to at least be sure that we're all telling our investigators the same thing, and that we are able and capable of handling things in a way that that can be reproduced by all of the laboratories that depend on us. So we came up with these guidelines for handling the biospecimens, and we put a definition of suspected is defined as a patient who has a pending test result to confirm their COVID-19 status. And we have some instructions for the submitting institutions. And basically what we did, we follow what was available through the CDC, the WHO, and of course our institutions. It was very important to bring the issue of following institutional guidelines because we are all in different states. And some people had some limitations that were imposed by the way the pandemic was being handled in their state that was different from others. Some, for example, the banks that are in California ended up closing operations earlier than the banks that were in other states. And we just wanted to be sure that everybody was just following whatever their institution, also where the bank resides, was requesting.
Milsa, sorry to interrupt. You have 1 minute. Sorry.
Sure. This is basically it. Packaging was another thing that we people were calling all the time, and instructions that we provided the groups as to what to do with the specimens and how to handle them. And then in this steering committee, just to point out that we have 4 representatives from SWOG. Next. At this time, we continue to follow the guidelines that we started following a year ago. Our laboratories are accredited by the College of American Pathologists under 2 programs. So we were lucky enough that we didn't have to stop any accreditation visits. We have a virtual and face-to-face in 2020 for the LAP CLIA, and we are expecting to have our virtual one for the biorepository in 2021. We follow the biorepository-based literature that is out there. We have people in all of the GBC steering committee subcommittees participating actively, and just following anything that comes our way. Next, I think that was the last one. Yeah, that's it.
Thank you, Dr. Ramirez, for keeping the tissue banking operations going during the epidemic. So we have a few minutes for questions, and I would like to start with a question to Dr. Halmos. Do you routinely check or test for seroconversion on your cancer patients?
Excellent question. We're in the middle of an actual research study looking at our patients with malignancy to see if they seroconverted. So as a research question, definitely yes. We should learn, quickly who, responds to the vaccine, how well, and what strategies can we have for, let's say, a bone marrow transplant patient who doesn't convert. Could they receive a booster shot? Should they, get a different vaccine? Should they receive passive immunization? So as a research strategy, definitely yes. In routine practice, we're actually puzzled right now. One of my colleagues and myself just spoke about this today, because we don't have a real avenue to do anything in terms of active intervention if somebody doesn't seroconvert after vaccination. But at the same time, I think the patient could be at least forewarned a little bit in terms of, maybe staying a little bit more protective as to their behaviors. So I don't think it's wrong to do it, but I don't think, we have a real, protocol yet as to how to address it with our patients. But outstanding question. In fact, we're in the middle of trying to maybe think about a research protocol where patients can be boosted with a 3rd vaccine, things of that nature, if by any chance we don't find seroconversion.
That's great, thank you. So I'd like to remind the audience that you could request being unmuted by raising your hand, and you could ask a question, or you could type it in through the QA.
There is a question in the QA.
So there's a question from Dr. Somlo. He's asked, did I see it right? Hydrochloroquine increases risk of dying. Is this due to patients rejecting standard therapy or drug effect?
I presume that question is to me, right?
Yes.
Yes. So, excellent pickup. The CCC19 registry did provide, treatment information and treatment outcome dependent on COVID-19 treatment. But this is not a randomized experience. I think we have to be very careful, with how we read into the information. Yes, indeed, it showed a little bit of added risk in patients who received, hydroxychloroquine, and also improvement in outcomes in patients who received remdesivir. And these are not, out of line with other observations in reality, but it's not a randomized experience. And patients early in the pandemic received hydroxychloroquine a lot more than later in the pandemic, when outcomes were better to begin with. So there's a lot of confounders. So I wouldn't view that as a very high level of information, but none of us are proposing the use of hydroxychloroquine today, that's for sure.
I have a question for Dr. Ramirez. Do you think, I know that you send out a warning that these have been, could potentially be from COVID-19 patients. Is there going to be, you think, a decrease over time or a concern about receiving samples of patients who were infected at the time that the sample was collected, or do you think somewhere along the way you'd have to screen any of the samples within your within the biobank for whether they were collected from active patients?
That's a great question. One of the issues that we have is funding and our capacity to do further testing, and following universal precautions. We consistently come to this point that if we follow universal precautions, we can we don't have the need at this particular point to be testing those samples. So that is why we put these guidelines, and our concerns are more for the creation of aerosols, like when you do a frozen section or something like that, if you suspect samples. Some of the banks that I interact with stop processing pulmonary any samples from lung tissue. So I think that ultimately, once some guidelines regarding storage come out, that probably is going to be what we're going to follow, but I don't think that we're going to go into developing some program that will introduce testing, because we don't do that for hepatitis. We don't do that for other diseases that are transmissible via samples.
So that's great. So I would like to thank our invited speakers, and we need to move on to our next agenda item, which is our publication update by Bill Barlow. So Bill, if you could come online and share with us the publication harvest for the past 6 months.
Yes, please go to the next slide. So some of this is a repeat from, we had the group meeting call in February. So some of these are repeated from that, but just wanted to make sure everyone is aware that we did have this publication, JNCI, from the SO221 about physical activity and its association with survival. Next slide.
So if you could move to the next slide. Thank you.
Yeah. I think we skipped, did we skip one and did it advance too far? Right. So this is also published. This is from SO307, looking at risk factors for bisphosphonate-associated osteonecrosis, and it's a comparison of the 3 treatment arms. Next slide. So an update on some publications that are in progress. We're working on S1416 and the final results from that. We're awaiting some TM data to be added to this for the publication. It was presented at ASCO last year. Next slide, please. And the trial S107 or responder was presented at the San Antonio virtually, and we have an intention to submit the manuscript to New England Journal in the next month or 2. There is a completed draft already available that is being edited, so we hope to have that published very quickly. Next slide, please. We have one manuscript that's been submitted to a couple places, hasn't found a home yet. It's an evaluation of serum thymidine kinase 1 in hormone receptor positive metastatic breast cancer. That was our 226 trial. The results are quite interesting, so I'm a little puzzled about why it's having trouble finding a home, but it will be resubmitted shortly to another journal. Next slide. That may be the last one. Let's see.
Yes, that's the last slide.
Thank you.
So thank you, Bill, and thank you for everyone that has worked on all of these efforts and publications. Next, we have Jeannie and Elda, our patient advocates, to give us an update.
Good afternoon. This is Elda Rayleigh, and pleased to bring the patient advocate update to you. Do we have another slide?
Yep, I'm advancing it. Matt, can you take over control? Somehow my thing is not working.
We're working with the slides. Let's go ahead and tell you a little bit about what the Patient Advocate Committee has been doing. You have a number of resources besides just Jenny and myself. There are a number of patient advocates on the committee that are also very interested in the work of the Breast Cancer Committee and serve on other SWOG committees like cancer control and the quality of life and symptom management, as well as being breast cancer survivors themselves. The Patient Advocate Committee has also been working hard on team science, which is a number of modules that can help researchers and advocates work better together. And we are working hard to add another module on health equity to that. Jenny, you want to tell us?
Yes, hi. This is Jenny Mason. I represent the Inflammatory Breast Cancer Research Foundation and the broader breast cancer community. As was mentioned in the publication pieces, the RxPonder trial was presented at San Antonio, which gave Elda and I an opportunity to present some information to the press and also be a part of an advocate educational piece for Exact Sciences later in the month. Since we weren't in person for San Antonio, many of the companies had later advocacy programs to update folks about what was happening. So it was great to be able to give some additional experience about how we as patients see that those results and where we want to see things move forward. Obviously, we were both very active in San Antonio and look forward to additional meetings with our work at ASCO and other activities where we have the opportunity to hear from other advocates in the breast cancer community so that we get a better sense of what people are looking for in clinical trials and what kinds of things we need to make sure we address to meet the needs of the patient population. We thank you for letting us bring that patient voice to the community of SWOG and hope that you, as we often say, will talk to us often and bring us in early in all discussions. Thank you.
We can move on to the next slide. So we will have a brief translational medicine subcommittee update to be given by Dr. Thompson and Garvin.
Thanks so much, Priyanka. And on behalf of Andy and myself, on the next slide, please, you will see that we are a quartet, really, of myself, Andy, Bill Barlow, and Kara Laubach, who meet once every couple of weeks to try and progress the translational element of all the clinical trials that SWOG is involved in. I have to say that Kara does a lot of the heavy lifting here to try and move things through due process. Next slide, please. We just wanted 3 brief slides to outline what's going on. Andy, if you could mute, please, you're giving us a bit of background noise. That would be great. Thanks. As you can see from the trials listed on the left-hand side, go back a slide, please. As you can see from the trials listed on the left-hand side, even trials as long ago as 1988 are continuing to yield good information with more novel technologies, for example, image analysis and some of the long non-coded RNA discovery going on with colleagues. And then you can see for 8897, for example, Don Johan has been trying to get more out of some of these very old samples, and with some success. And then Priyanka Sharma has presented, and now we've seen published some of the innovative work coming out of 9313. And then as Don Hertz and Tom Budd have been demonstrating, going back to some of these trials from even 20 years ago, by applying for resource funding, it's been possible to make sure that we can get some additional information out of those older trials. Next slide, please. Thank you. Moving forwards, you can see that the androgen receptor is exciting more interest, and Anthony Elias and his colleague, are working on that, doing some wonderful behind-the-scenes preliminary work before moving into the clinical samples. Jimmy Ray and colleagues have been working with a commercial company on a TK assay, which has got an FDA filing and a manuscript being written. And Dan Hayes, who formerly led all the translational medicine work, has continued to be very engaged with the CTC side of things. You've already heard of the excitement of the S1007 Rx-Bonder trial being presented at San Antonio, and delighted to report that Funda Merrick-Benstam and Kevin Kalinske are working hard to develop both blood-based and tumor-based markers to study further that innovative trial. Next slide, please. So this is really the final listing of some of the things going on. And you will see from that final slide here that as we come closer towards the trials that have been more recently started, we're now finding that by working with CTEP, that we're able to explore things that didn't exist when these trials were initiated. For example, looking at the PD-L1 side of things, and to be very innovative in what we're trying to do, having to set up MTAs, yes, but it's worth doing these things so we can get the most out of these recent trials. And you can see that for S1418, Lausch's trial, that whole exome sequencing of the tumor and then of the ctDNA looks to be in hand. And then finally, as further proposals get developed, what I want to do is just emphasize on behalf of myself, Andy, Bill, and Farah, last slide please, that we're very open to any ideas, any suggestions, any things that any one of you out there would like to look at. Please feel free to approach us. We will do our utmost to support you in doing good work with the trials materials that are already being collected. And with that, happy to take any queries or questions. Andy's on the line, Bill's on the line, and Cara, as ever, is behind the scenes making things happen. Thank you.
Thank you, Dr. Thompson. Seems like a lot going on in the Translational Medicine Subcommittee, and we thank all our investigators to stay engaged and use the resources that have been generated by our well-conducted trials. So we'll move on to our next section, which is the review of some of the open SWOG and CTSU studies. For this, we will have individual study champions come and present their brief updates. This will be a brief update of every study, and we won't be taking questions during this time. This is a list of studies that we will review today, and this is by far not the comprehensive list of studies that we all accrue to. The update for other studies is available online in our agenda. So the first one is SWOG 1418. Laish, this is yours.
Yeah, so I would like to thank all of you for supporting this SWOG 1418 study, because we had a remarkable success with this study in terms of accrual. So even during the past year, we accrued 20-25 patients per month to the study, and it's going to probably close by the end of next month or July. We had an amendment that was activated, I think, in February, to increase the sample size from 1,000 to 1,155. This was done so that we could adjust the PD-Ligand 1 positivity from 1% to 10%. And this adjustment was requested by Merck based on the available data that now suggests that it's a better threshold to define the IO therapy sensitive population based on their metastatic results. So we also have an important new amendment that I hope you will all support who contributed patients to this study. This is a groundbreaking idea, and it tests mammographic density changes in patients who received pembrolizumab. So the question that Dr. Banu Arud, who is the champion and PI of this sub-study, asks is whether immunotherapy could actually function as a chemoprevention modality, reducing mammographic density. So once this amendment is approved, you will be approached to upload routine mammography imaging to a central website. And I just want to reassure you that we are working on the next generation of studies in that space, because it's a very important unmet clinical niche. These patients remain to be at high risk for recurrence. And regardless of what S1418 will show, we actually would like to populate this space with exciting new studies that you will hear later on.
Next update is for SWOG 1706 by Dr. Jaxi.
Hello, thank you for the opportunity to update on our phase 2 randomized trial of olaparib administered concurrently with radiotherapy versus standard radiotherapy alone in the management of inflammatory breast cancer. So this is a trial that has been underway now for nearly a couple of years and is making good progress. We're not quite at our monthly accrual rate. As you'll recall, we were hoping for 5 patients a month for 5 years because inflammatory breast cancer is, of course, not incredibly common. And we've been more like averaging about 3 patients a month. You can see us flitting around there, some months even surpassing 5 patients a month, even during COVID, but some months coming short of that target. And so we're continuing to work with our patient advocates. We really want to thank Ginny and Elda for their incredible help from conception through execution of this, and we'll brainstorm with them about this. We currently have, as of April 14th, 2021, as on the slide, 78 patients accrued of the 300 total. And again, I think that's doing well, but we might be able to do better. And one idea that we'll talk about amongst the study co-chairs, particularly the radiation oncologists, is the possibility of giving an alternative to the current standard arm, which is QD radiation, and perhaps allowing BID radiation, which is what certain centers prefer for the standard arm. We wouldn't be able to do that in the olaparib arm, but we could potentially consider expanding our definition in the control arm. So I'll keep you posted on that. But thank you for your support and your interest, and please keep accruing to this trial.
Thank you, Reshma. Next, we have our brand new study. We just opened. Let's see if the slide will advance. S2007, a phase 2 trial of sacituzumab for patients with HER2-negative breast cancer and brain metastasis, whose PI is Dr. Brennan.
Thanks. I appreciate the opportunity to update on this and to ask for all of y'all's help. Just a reminder about S2007. It's a study of SASI for patients with histologically confirmed HER2-negative invasive breast cancer that's metastasized to the brain. There are a couple key things to remember: that patients must have had CNS progression after any previous CNS-directed therapy, and that could be radiation therapy, surgery, or any combination thereof. They also need to have a relatively modest steroid requirement when they go on study. They can't be on high doses of steroids, as patients tend to be a little bit more problematic. And otherwise, the rest of the criteria are relatively straightforward. The schema is on the right there, as you can see. The patients are eligible after the progression from radiation surgery. We're going to enroll 27, and they're going to receive standard doses of SASI, 10 milligrams per kilogram, day 1 and day 8 of a 21-day cycle. And if we see 3 or more responses, then we will continue accruing to a total of 40 with MRI of the brain and for intracranial imaging, as well as extracranial assessment every 8 weeks. Next slide. So as mentioned, the study was activated in December 15th, And so we now have open or in the process of being open 162 centers and their affiliated sites. I have reached out to some of you who have opened it, and I thank you for opening the study. And if there are any accrual problems, please let me know as we get this going. And I probably will bug some of you going forward as we, see how things go, just to see if there are any accrual barriers or if there's anything we can do. But just to continue looking for any patients. It's only going to be 40 patients, but the patients are going to be relatively less frequent than for some other studies. Thank you.
So we encourage all of you to consider opening this study. This is an area of unmet need, and most of us don't have very many competing trials for these patients. It's an active drug for both triple negative and hormone positive systemic disease. So that aspect, it's a good drug, and we would feel reassured that the systemic disease would be treated with a robust agent as well. Okay, next we have EA 1181, which would be presented by Dr. Tang.
Thank you. Thank you very much for the opportunity to update the EA 1181 and the AO 11801. And just remind each other that this is can you hear me well?
Yes. Okay,
good. Thank you. Yeah, just to remind everyone, and this is a de-escalation trial for HER2-positive neoadjuvant treatment. As you recall, one of the standard neoadjuvant therapy for HER2-positive tumor is from the neosphere, where patients are given THP pre-op, followed by surgery, followed by post-op chemotherapy that is SPECT-based plus anti-HER2 therapy. However, the question is, in patients who have achieved complete response, PCR, do we really need chemotherapy post-op? So that is the idea of the trial. So in this trial design, patient will be getting basically pre-op TPH, followed by surgery. If they do have PCR, then they will get basically biologics only without chemotherapy. That is the experimental arm. And they'll get a dual anti-HER2 therapy for 1 year. For those who do have residual disease, then they'll be randomized to the second protocol, that is the Compass HER2 RD residual disease arm, where they'll be randomized to receive 1 year of TDM1 per Catherine trial, or they'll get the experimental arm.
Dr. Tang, we will discuss 11801 separately. So if you just focus on 1181.
Sure. So far, the trial has been started in February last year. It's just over a year. And there are 356 patients enrolled. And that's out of 1250, so 1/4 enrolled. And SWOG is actually lagging behind the other cooperative groups. So we do need to work on this. And in terms of update, there are recent update from the protocol. Amendment 2 changed the tumor size for patients without nodal involvement to above 2 centimeters rather than 2 or above 2 centimeters. For patients with a nodal involvement, any tumor size is eligible, and that's except T4. The third amendment was just approved and should be activated in a few weeks. The important changes include the patients who do not have IHC3+, their FISH ratio less than 2 is now considered not eligible, even if their HER2 copy is over 6. An important reminder is that the mandatory blood samples are connected, as well as optional blood and archive tissues, and that is from the diagnostic biopsy or surgical excision. There's no research biopsy. Finally, so far, 80% of patients have been consenting to tumor and extra blood connections, and the blood will be sent to 2 places, either the Epic Sciences externally or ECOG Accurate Biodepository with a different FedEx number, so please don't mix them up. Number two is that do not refrigerate the collection tubes. They should be kept at the room temperature. And lastly, this tube need to be reverted to after they're drawn to prevent the blood clotting. Thank you.
Thank you, Dr. Tang. An important study needs our support. Looks like despite COVID, the study is off to a good start. Next, we have Compass HER2-RD or A011801, whose SWOG champion is Dr. Murthy. Is Dr. Murthy on? Not, I will present the update. So this is the companion trial to the Compass PCR. So these are patients who have residual disease, either while they participated in Compass PCR or residual disease after receiving standard preoperative therapy for HER2-positive breast cancer. And these patients are randomized to receive TDM1, which would be standard of care, or TDM1 plus tucatinib. You can see the eligibility criteria on the right-hand side of the screen. If patients have ER-negative disease, and any amount of residual disease is allowed. For those with ER-positive disease, it has to be lymph node positive disease post-op, and patients have had to receive 6 or more cycles of adequate chemotherapy preoperatively. This was activated earlier this year, and I know many of the sites are still in the process of getting it through their system. We sure are. And 4 patients have been accrued thus far. If you have any questions, you can reach out to Dr. Murthy. Next, we have BR004. Dr. Cobain is our SWOG champion.
Hi there. So just a brief update on this study. Just want to review the schema first. This is a trial for patients with HER2-positive metastatic disease being treated in the first-line setting. And patients are randomized to our current standard of care, weekly paclitaxel plus trastuzumab and pertuzumab every 3 weeks until disease progression, versus that same combination with the addition of immunotherapy, atezolizumab, administered once every 3 weeks. So the goal accrual of this study is a total of 600 patients. This study has been accruing rather slowly. To date, there are 104 patients randomized, 179 in cumulative screening. And I just showed there what our accrual has been within SWOG. We would love to increase our accrual to this study if possible. And if you go to the next slide, I'll just talk about a few kind of changes to the study that have happened and important notes, and I'll just make brief mention of an amendment that is currently in progress. So as a reminder, just as eligibility for this trial, patients must have measurable disease. Want to just remind everyone that patients with CNS disease are eligible, provided that they meet certain criteria. If they are asymptomatic or treated CNS metastases that are asymptomatic, they often are eligible, but leptomeningeal disease is excluded. One other thing that may make it a little bit easier to get patients on to this study is just to be sure we're all aware of the fact that while the central testing of HER2 positivity and PD-L1 status is being confirmed, patients can actually receive a loading dose of trastuzumab and pertuzumab actually prior to their randomization. But just a reminder about this, that if they receive a loading dose with a trastuzumab biosimilar, they are not eligible, and the trastuzumab not biosimilar, the traditional form, can be provided through the study. So just something to be aware of. There were also just some temporary allowances that were instituted as a result of the pandemic that would only result in a minor deviation for this protocol. So up to 2 doses of non-consecutive paclitaxel can be withheld per 6-week cycle just to decrease the frequency of treatment, and this is per investigator discretion. And then you can also delay a 6-week cycle of therapy in the absence of toxicity, just for logistical purposes in the midst of the pandemic, with only a minor deviation. Want to just make brief mention of the fact that there is another amendment that has been submitted, not yet approved, to make things even hopefully a little bit easier with regards to this protocol. That would include the ability to allow docetaxel as the chemotherapy as opposed to just paclitaxel as it currently stands. And then also to potentially, with that first cycle of therapy, administer the chemotherapy in addition to the loading doses of trastuzumab and pertuzumab while awaiting randomization. The current amendment will not allow for use of Phesgo, but that is something that is being explored for the future.
Thank you, Erin. And I see some comments in the chat box around the biosimilar question. It'd be nice if the trial actually allowed it instead of just providing the trastuzumab, because a lot of centers have switched to using biosimilars, and certainly it creates questions in our patient's mind when we say, well, you can get trastuzumab if you're on the study, but if you're not, we're going to give you a biosimilar. Creates the idea that somehow those might be inferior. But again, you can take it back to the study team.
Will do.
I will just go back to 11801. So Dr. Murthy was on, but there's some technical issues, so she couldn't unmute herself. And also there is a comment from Dr. Corday, just reminding everybody that for patients that have participated in the COMPASS PCR study, they don't automatically enroll on the COMPASS RD or residual disease study. If they have residual disease, these are two separate studies. So patients have to re-enroll. So for sites that have both open, to keep that in mind and offer the second study. So we'll move on to our next study, which is Alliance 011202, Dr. Maman.
Thank you, Dr. Sharma. So this Alliance trial is a trial for individuals who have breast cancer which are node positive at the time of diagnosis, who then go on to have neoadjuvant chemotherapy. And then at the time of surgery, they're evaluated with a sentinel lymph node biopsy. And this trial is for those individuals who have a positive sentinel lymph node, either identified intraoperatively, at which point they're randomized, or are identified on permanent pathology, and at that point you're able to be randomized. So in this trial has two arms, so fairly straightforward. One arm is a completion axillary lymphadenectomy, standard levels 1 to 2, followed by radiation to level 3, so the non-dissected portion of the axilla, versus the second arm, which is axillary radiation to the entire axillary basin without any further axillary surgery. This trial has accrued quite well, but it was on a fairly long hiatus after it was temporarily suspended in April of 2019, and it was only reopened in May of 2020, so it was slightly longer than 1 year hiatus. And the real reason was that the anticipated number of patients who were not evaluable for the primary endpoint was higher than expected. So there were a few changes that were made with the subsequent amendment after the trial was opened in May. There was some adjustment to the payment structure to encourage the enrollment of individuals who are evaluable. There was an increase in the sample size, which was important to be able to get a number of individuals to the primary endpoint. And also an additional change was that the study duration in terms of follow-up was increased from 5 years to 8 years. So those are the key amendments. Since the trial has been opened again, it's been accruing quite well. You can see the number of screened individuals is more than 3,800 individuals, and almost 1,800 have had the intervention. So the expectation is that this trial will be open for another year, so approximately another 11 to 12 months. There is another upcoming amendment, but which is being reviewed right now at CTEP, and this is really focused on adding blood and tissue collection for some correlative studies.
Thank you, Dr. Maman. Next, we have SWOG 1501, Dr. Floyd.
Thanks. We can go ahead and move to the next slide if it's okay. So as you know, 1501 is a study looking at carvedilol as a means to reduce the risk of cardiac dysfunction on men or women with metastatic HER2 overexpressing breast cancer. Go ahead, next slide. Focus on this slide. So this is our progress to date. As you'll see, we're up to 235 patients accrued. I think within the next month or so, The third arm, or the observation arm, will be closing, so it will only be the investigational arms 1 and 2 that will be open. You can look at the progress below. I'd say we kind of been trending around 5 patients a month, which is lower than we would like. Albeit some sites have had very robust accrual, as you can see. So we have met with several different entities discussing this, and we have an amendment forthcoming expanding eligibility, allowing up to 4 lines of therapy, which I think will help. It also clarifies biosimilars are currently allowed, but it clarifies biosimilars and also includes some of the newer HER2 targeted agents that have been released. We're working, we don't have the ability to use the champion mechanism since this is a cancer control trial. So we're using other avenues to engage the other cooperative groups. Thanks to SWOG, the vast majority of patients have been accrued through SWOG sites. We're going to try to improve accrual by meeting with the other groups at a meeting next Friday with Alliance to work on this. Also exciting, we are getting ready to ship biospecimens to start baseline translational work. So thanks to everyone. Check to see if it's open at your site. Email me with questions, and thank you.
Thank you, Justin. Next is S1714 and Dr. Trivedi.
Hi, thanks. So this is S1714, a prospective observational cohort study to develop a predictive model of taxane-induced peripheral neuropathy in cancer patients. Study is accruing very well. We're at 78% accrual. Again, this is an observational cohort study of patients who are receiving taxane-based chemotherapy regimens. Right now, we're reviewing the data to see if there's any significant missing data or imbalance in the groups, particularly in the setting of COVID-19, and trying to see if we need to consider increasing the accrual goal. We're also working on some of the translational medicine work with our TM chair, Dan Hertz, but things are going well. Please feel free to reach out if you have any questions or concerns about the trials.
So the study is accrued very well, and thank you everyone for supporting the study. Next, we have 1703, Dr. Accordino.
So this is our metastatic disease monitoring study for hormone receptor positive, HER2 negative patients. We are still currently accruing, albeit it's a little bit slower than we'd have hoped. We did amend our protocol last February, right before COVID, to make the requirements a little bit easier for the sites and only require CA 15-3 or CA 2729. If that, based on feedback we've received here, we're also going to submit another protocol amendment upcoming about the registration step 1 eligibility to lower that from 2 times the upper limit of normal for any of the breast cancer tumor markers down to 1.5 times the upper limit of normal. We have heard that there have been patients who've had elevated tumor markers, but just not elevated enough to meet criteria for the study. So hopefully that will help. If there are any thoughts or feedback or suggestions to improve accrual, please send me a message so we can help do better. Thank you very much.
Thank you to all our study champions for championing these studies and keeping our membership aware of the changes that are coming. So we'll move to our next section, which is reviewing key developing concepts. The first 2 on the list are DETECT 1 and DETECT 2, to be presented by Dr. Kulinski on behalf of himself and Dr. Bardia.
Thank you, Dr. Sharma. If you don't mind going to the next slide. So Dr. Bardia presented this in the working group earlier this week, and it would just be helpful to discuss DETECT 1 and then hopefully DETECT 2. So DETECT 1 is a smaller study which is being put through we have a capsule together that's being submitted for review within SWOG, which is a study for patients with triple-negative breast cancer, stage 2 or 3, with residual disease, who've completed all of their chemotherapy or all of their systemic therapy, capecitabine and or immunotherapy if appropriate. They're within the 18 months of their diagnosis, have no clinical evidence of disease, in which point we would be collecting cell-free DNA. And if we identify that their cell-free DNA is positive, then they would receive sacituzumab govitecan for 6 months. And before doing that, we would be doing systemic imaging. We would also have later on systemic imaging as well. We would be monitoring with cell-free DNA every couple of months, including the time that they are on their sacituzumab govitecan and then later. And we will be looking at clearance of cell-free DNA. We'd also understand the rate of being radiographically having occult disease at that time. And this would serve as initial data to help us determine sample size, et cetera, and a little bit more about the population if we think about a larger randomized study. And we do have support for this study from Gilead as well as Natera to do the cell-free DNA. You move to the next slide.
So next slide is actually a question for our audience to gauge their interest if they would open Detect 01 if it was available at your site. And just a reminder, as you vote, after you make your selection, please remember to hit the submit button on the bottom right-hand side of the screen. Otherwise, your vote will not register. Can we close the poll? You should be able to see our poll results here. Right? So for those that answered, a good proportion are supportive of the study. Thank you. So Kevin, you can take that information back as you're finalizing things.
So Priyanka, if I could just interject here. So I noticed that 171 of us are on this call and 132 did not respond to the query. It's a really important part that please, if you have the opportunity and you are online, respond to the queries, because we really want to hear your engagement and your thoughts on these trial proposals. So this only succeed if everybody supports the studies. And at the beginning, we want to understand enthusiasm or the lack of it for these concepts. And I understand that some of the people on the call may not be clinicians or physicians who put patients on studies, but I suspect that more than 25 or 27 of us are actually practicing clinicians. So please be engaged and respond to these questions if you have a chance. And there will be a few more during the meeting.
So we'll move on to the second concept in this theme, the detect.
Right. Yeah, thank you. And also just to reiterate a point that Dr. Prasad had said earlier, this would potentially fill the space when we think about S1418 closing, this adjuvant space in patients who are high risk, just to see whether or not these patients have cell-free DNA, as well as determine whether or not they can clear and or have an improvement in their outcomes if receiving sacituzumab govitecan, which is really what we're hoping to answer with the future proposal with DETECT-2, which would be a definitive study, a larger study, the same sort of population, where we would have more patients that we would be screening and hopefully going on right now. And we're anticipating, looking at a primary endpoint of overall survival if we're comparing doing sacituzumab govitecan for 6 months versus doing close observation for those patients who are cell-free DNA positive. In this study, again, we would screen. If they're cell-free DNA positive, we would do imaging, make sure they don't have occult metastasis, and then they would be randomized. And the primary endpoint would be overall survival. You can look at secondary endpoints that are listed here. There have been discussions about this also, us collaborating with our Alliance colleagues with a different study that they're looking at with imaging that we could potentially be a companion study for. But again, this would be a more definitive study that DETECT-1 would help us be able to appropriately power and answer some questions before moving on to this.
So we have a poll question for this study as well. Matt, we can close the poll in about 30 seconds.
So maybe here, yeah.
So we have a few maybes and some no's because of competing studies. But majority are supporting the concept. So we will hear more about these two studies at our upcoming meetings. But Kevin and Aditya, Bill, and the whole SWOG team is working very hard to bring these trials, as Dr. Pushtai mentioned, to fill in the gap that will be created once 1418 closes.
Thank you.
So the next study is TAC2, which I will present. It's TIL-adapted chemotherapy optimization in triple-negative breast cancer. And a lot of you may have seen versions of this over the last year. The idea of using tumor-infiltrating lymphocytes as a selection criteria to de-escalate or tone down chemotherapy for patients with triple-negative breast cancer. So this is a non-inferiority randomized design. And the interventions actually in the neoadjuvant setting or preoperative space. This trial will include patients with node-negative, triple-negative breast cancer that have greater than 30% TILs, and TILs will be assessed centrally. But for this, a specimen doesn't need to be sent. An image of an H&E slide can be uploaded on a site, and the reading will be provided back to the enrolling site within 48 working hours, whether that patient meets the criteria for greater than 30% TILs or not. The patients will be randomized to receive standard AC followed by taxane chemotherapy, or the experimental arm, which is 12 weeks of a platinum and taxane treatment. All patients will undergo surgery and then will be followed. The primary outcome is 3-year recurrence-free survival in all patients and multiple secondary endpoints as listed on the slide. Patients who have a PCR would be recommended to not receive any further adjuvant chemotherapy because of achievement of PCR, we assume that their outcome is going to be excellent, and further treatment in this setting is not going to improve upon that already excellent outcome. Patients with residual disease would be recommended to receive additional chemotherapy, and that would be tailored based on the arm that they were assigned at the time of randomization. This is a non-inferiority design and would take to enroll randomize about 610 patients to show non-inferiority with a hazard ratio upper bound to be set at less than 1.75. The trial will have early stopping rule for futility based on significant PCR difference at about 50% of patients enrolled. So that we would make sure that the experimental arm is not underperforming the standard arm significantly, at least in terms of PCR. And I see several chat questions that are coming up. So before we move to questions, since it's the first time a lot of you are seeing this, I'm just going to look through those to answer if I can. There. So there are questions regarding platinum. What about in situations where providers are already including platinum along with ACT in their standard treatment regimen? And of course, that practice varies across the country. Our thought is, since we're picking patients with node-negative disease, so lower clinical risk disease, most of those patients probably aren't receiving platinum as part of their standard neoadjuvant treatment. But again, that would have to depend on individual practices. So we have a few questions around this concept. I think it moved to, okay. So the first question is, how would you approach treatment for a 52-year-old woman who's in otherwise good health with a 1.2 centimeter node negative, triple negative breast cancer? So it's a T1C, barely made it to T1C. Would you recommend neoadjuvant chemotherapy followed by surgery, or surgery first followed by adjuvant chemotherapy? No chemotherapy at all. For this one, we really do have an option for those that didn't vote in the previous questions to mark that they don't treat patients or not clinicians. So we can get a count on that as well. Matt, we can close the poll in about 20 seconds. So out of those that voted, looks like we have half and half in terms of preoperative chemotherapy followed by surgery or the reverse sequence. So move on to the next question. So very similar situation, but here the tumor size is 1.8 centimeters, 52-year-old woman in good health. So kind of towards the other end of the spectrum for T1C disease, and how would you approach this patient? And the reason we're asking these questions because we anticipate two things. First, we want to understand what providers are doing for T1C disease. And if we were to include these patients in a neoadjuvant trial, would we have traction? And also there is going to be an adjuvant concept in this space too that will include patients with T1C disease. I think, Matt, we can close the poll in about 15 seconds. Thank you. So a little bit more shift towards neoadjuvant treatment in this situation. The last question is going to be what we've asked for every concept, but a recommendation was made to just pull up the schema first for a few seconds before I asked a question about interested in enrolling in this study. So here's the schemas back up, randomization between 12 weeks of platinum taxane or AC taxane for node-negative patients with high TILs. And here's the last question. Will you or your site open TACT if it was available? And Matt, we can close the poll in about 20 seconds. Thank you. So looks like we have a decent amount of support among those that voted and some maybes. So we'll move on to our last concept, which will be presented by Dr. Pushtai and Dr. Cobain. Don't know if Erin's still on. She said something about having to be back in clinic.
So Erin Cobain, who is the PI of these studies, is not available, then I will present this to you. So this idea really grew out from a number of trial arms that I-SPY have conducted and announced. So you may be aware that 3 arms of the I-SPY study, including pembrolizumab plus Taxol compared to Taxol alone, the durvalumab olaparib arm combined with Taxol, again compared to Taxol alone as the control, and the carboplatin veliparib arm. Both of these showed that you can improve the pathological CR rates in ER-positive disease. And the molecular analysis of the samples show that there is a particular subset of ER-positive patients that we call MP2 or MammaPrint ultra high, which selectively benefited from adding these other agents to Taxol. So what this slide shows you is the PCR rate in the ER-positive, MammaPrint high, but not very high, MP1 group, where there was no difference between the immunotherapy drug plus olaparib versus control, about 9 and 10% PCR rate. In the MP2 group, the same regimen produced a remarkable 64% PCR rate compared to 22 in the control. So what makes this really interesting, that the molecular features of the MP2 group, so again, this is the MammaPrint ultra high group, compared to the MammaPrint high, regular high, or MP1, had a much higher proliferation signal and a much lower estrogen expression related signal. There was no difference in the immune gene expression in these 2 cohorts. So the high proliferation suggests that this is indeed mechanistically quite plausible, that this is the group that benefits from chemotherapy, and we can augment the effect of chemotherapy, either adding on another drug like carboplatin or the immuno-oncology drugs. And the low expression of the ER-related signatures suggests that this is the ER-positive group that's the least likely to benefit from the subsequent adjuvant endocrine therapy. So based on these 3 studies, we proposed the following design, which is on the next slide. Can we move to the next slide? So the study is a randomized trial that would take MP2 patients. So how do you select them? So Agendia agreed to provide the MP2 testing or the MammaPrint testing free. And the overall eligibility criteria for screening is any ER-positive patients whom you would consider for adjuvant chemotherapy. And if they are eligible for adjuvant chemotherapy, they of course would be also eligible for getting the same regimen neoadjuvantly. So any patient who is eligible for chemotherapy would be screened with a MammaPrint assay. And if they are MammaPrint high, ultra high, then they get randomized to a third generation neoadjuvant regimen, dose dense AC, weekly Taxol, versus the same regimen plus an immuno-oncology drug. And AstraZeneca expressed some interest to support this trial with drug. So they receive treatment for 20 weeks and then they complete surgery, and subsequently everybody receives physician's choice standard of care adjuvant endocrine therapy. So the primary endpoint of this study is invasive disease-free survival. And the secondary endpoint is a PCR rate improvement. And we also have quality of life studies during the chemotherapy and immuno-oncology drug component of the trial, and also during follow-up. So I'd like to see what is the recovery rate at 1 year and 3 years after initiation of the treatment. And there is a translational medicine component that we will be doing jointly with Energy, and it will be led by Matthew Ellis. So just to point out to you the overlap between the MammaPrint high and the recurrent score high group, there is about an 88% concordance. So if people are recurrent score high, 88% of the time they are also MammaPrint high. And about half of the MammaPrint high population would fall into this MammaPrint ultra high or MP2 group that this study is designed for. Next slide, please. So this is the sample size that is required for this trial if we assume an 80 versus 87% invasive disease-free survival improvement. We would need 875 patients randomized. This translates to about 900 and so patients that we would need to accrue after accounting for about a 10% sort of attrition rate or deviation rate. So I just wanted to summarize at the end the 4 points that I think make this study interesting. So this is a prospective study to test the hypothesis that has been raised by a number of small independent phase 2 trials that we could improve efficacy of neoadjuvant chemotherapy or adjuvant chemotherapy really in this high-risk ER-positive population. There are really no major competing trials through the NCTN currently in that space. And if the CDK4/6 studies fail to improve long-term outcome with longer follow-up, then really we haven't made any advance in efficacy in terms of adjuvant therapy or neoadjuvant therapy for ER-positive cancer for about 20 years. So it's really the AIs and the bisphosphonates were the last major advances in terms of efficacy in ER-positive disease. And this is also a study design that could settle this question that how an improvement in PCR rate translate into invasive disease-free survival improvement in a particularly high-risk biomarker-selected ER-positive population. And this is the only sort of neoadjuvant IO trial which does not include an immuno-oncology drug as a maintenance phase. So it really isolates out the impact of making the neoadjuvant component more effective. So this is the design, and then we have a few questions for you. So
the first question we have is, in your practice, what proportion of patients with ER-positive stage 2-3 breast cancer receive neoadjuvant chemotherapy? Or I would say are eligible to receive. And Matt, we can close this poll in about 20 seconds. Okay, so we see a good distribution here. Our last question is, will your site open and enroll on this trial if available?
I think if you'll need to update the polling component. Yeah.
We can close this in 15 seconds. So it looks like we have a good amount of support, and we'll take it back to Dr. Cobain. So this was our last slide.
Yeah, so I would like to thank you all for joining this spring Zoom meeting. I also would like to make an announcement that I think is important. I would like to thank, on behalf of all of us, Julie Grelo, who served as our executive officer for the past many years, and it really made important contributions not only to our trial portfolio, but shepherding our studies through the bureaucracy of SWOG and CTAP. So I would like to thank Julie for doing this. Unfortunately, she couldn't participate in this event today because of her responsibilities for ASCO. I also would like to welcome Anne Chang, who, as you probably are aware, is our new executive officer. And I couldn't be more delighted to have Anne in this role. She's my colleague at Yale, a very accomplished lung cancer investigator, and also our chief network officer. So Anne, again, unfortunately couldn't participate because of a prior engagement that she had and could not get out of, which was made before she was selected for this role. I think this is a very welcome development for all of us, and I look forward on behalf of you to work with Anne and implement these ideas that you just heard about. And thank you again for your support for SWOG and putting patients on our studies and contributing ideas.
Thank you, everyone. I want to thank all our presenters for staying on time and letting us get through this very packed agenda in 2 hours, and hope to see all of you in person in fall.
Bye-bye, everybody.